Assalamu alaikum students, and welcome to your clerkship ophthalmology video sessions. Today we will be starting with a brand new theme of sudden painless loss of vision, and the first differential within this theme is that of retinal vascular occlusions. As the name of this theme indicates, the patient tends to lose their vision pretty suddenly, minutes to hours, and it is not accompanied by any meaningful amount of pain. Where there is some semblance of pain or vague sensation of pain, obviously we will mention that as we go along. And as you will see, most of the causes that we discuss within this theme have their origin in the neural retina, the neural part of the eye to be more precise, i.e. the retina and the optic nerve. And for today, our laundry list includes an overview of the retinal circulation, some investigations that we've already talked about before. We'll just quickly go over them. Then the arterial and venous occlusions. We'll talk about their etiology, their epidemiology and pathogenesis, the presentations, investigations, management, and complications. These diseases are somewhat important, although they're seen in a relatively older demographic. And especially retinal arterial occlusion is something that is probably seen in a demographic which is very close to the mean age or life expectancy of this country. But the life expectancy has been gradually increasing, so you do tend to see these types of patients more frequently now. So let's just talk about the circulation of the retina, and I'm sure you know this, that the retina has a dual blood supply. The outer four layers of the retina, the layers that are closest to the choroid and the sclera, are served or are provided nourishment by the choroidal circulation. And the inner layers, the inner 6 layers, are supplied by the retinal circulation. The watershed zone is at the outer plexiform layer. There is a very special artery which is called the Cilio-retinal Artery. It's an offshoot of the ciliary circulation or the choroidal circulation, but it supplies the foveal area, all of the layers of the foveal area. And that is somewhat important, and we will see why that is important when we talk about retinal arterial obstructions. So this is a picture on the right of a picture on the left of the right eye. This is the right eye because the optic disc is relatively to the right of the fovea. There is no cilio-retinal artery in this picture. The picture on the right, again of the right eye, has a cilio-retinal artery. And as you can see, this artery is not branching off the central retinal artery. It is coming off the edge of the disc. That means it is coming off the choroidal circulation directly and supplying the foveal area of the retina. And since this is basically a blood vessel that is supposed to supply, that is originating from choroid, which is supposed to supply only the outer layers, since this blood vessel has now entered into the inner 6 layers, it supplies the inner 6 layers. So this foveal area, if you have a cilio-retinal artery, would be supplied by the retinal circulation, and in addition by the cilio-retinal artery as well, the inner 6 layers. So this is seen in about 25% of the population, of the normal population. So about 1 in every 4 individual would have a cilio-retinal artery. So this is a patient who has a double cilio-retinal artery, again from the choroidal circulation. So the area that is perfused by the cilio-retinal artery in this case is greater as compared to if you have a single cilio-retinal artery. This is where the cilio-retinal artery, this is a picture of the cross-section of the eye. This is the optic nerve, and these are the certain retinal vessels as they are entering into the eye. This is the posterior ciliary artery, which basically forms the choroidal circulation. And as you can see, this is the cilio-retinal artery, which is branching off from the source of the choroidal circulation, i.e. the posterior ciliary arteries, but it goes on to supply the inner layers of the retina. So in the area of supply of the cilio-retinal artery, if a person has a cilio-retinal artery, the foveal area has now 2 sets of circulation for the inner 6 layers, the normal central retinal vasculature as well as the cilio-retinal artery, which is somewhat important, and we'll see why that is just in a bit. So this is the cilio-retinal artery. One more thing about the retinal circulation before we start talking about the the investigations and then the vascular occlusion is that the arteries tend to cross over the veins, which is sort of opposite of what happens everywhere else, where the veins are more superficial. And as you can see, this is the artery, the one that is shown by the red arrow, and a branch of the artery crosses over the vein. So wherever we have a situation when an artery and a vein have to cross over one another, the artery is superficial, i.e. towards the vitreous side. The arteries appear thinner, the vein appears thicker, and we'll talk about why that is in a bit. At this point where the arteries and a vein cross over one another, it's called an atriovenous crossing. They have a common adventitial sheath. So the outermost layer of the blood vessels, the tunica adventitia here, is common. And that is somewhat important because under normal circumstances, the vein is now protected from the effect of the intraocular pressure by the artery. Because the artery is taking most of the pressure, the artery normally is very elastic and muscular, so it is sort of taking on the effect of the intraocular pressure. The pressure within the central retinal artery and its branches is obviously much higher than the central retinal vein or its branches. So it is bearing the brunt of the intraocular pressure because it's on the top. So it's sort of shielding the vein. It's just like a mom hen takes her babies under her wings in case of danger. The reason that arteries appear thinner, as I've just said, that the arteries do appear thinner, is that their caliber is less as compared to the caliber of veins. So this is what a normal atriovenous crossing looks like, that this is the artery crossing over the vein so as to protect the vein from the effects of the pressure of the eye, because the pressure in the vein is slightly greater than the intraocular pressure. So if you have a vein crossing over the artery, the vein would be compressed by the intraocular pressure, and from the posterior aspect, if the artery was crossing under the vein, it would be compressed by the artery. But in this case, because they have a common adventitial sheath, the artery is shielding the vein. Investigations are basically just two: fluorescein, fundus, angiography, and OCT. We have talked about FFA quite extensively before. I've just reproduced this for your own review. This is what an FFA looks like. This is the left eye, or an FFA of a left eye, because the disc is relatively to the left of the fovea. These are the retinal vessels, and they appear to be highly fluorescent, and because they have tight junctions in the vessel walls, the dye does not leak from them. The fovea appears dark, and that is dark background because there is an area around the fovea which has no blood vessels. It's called the capillary free zone, so that you have light that can go directly to the photoreceptors at this area. And you can't see the choroidal circulation because of the xanthocell pigment. So the choroidal fluorescence that you can see everywhere else, this background fluorescence, you don't see here because of xanthophyll, and in addition, the high density of the retinal pigment epithelium in this area. The choroidal details are generally obscured because as the dye leaks from choriocapillaries, it stains the Bruch's membrane, and that prevents you from viewing the choroidal vasculature in detail. And this is the left eye. We've already talked about why this is the left eye. We have talked about OCT before, and again, we have talked about the foveal area, we have talked about the Bruch's membrane area, foveal area we talked about extensively in diabetic retinopathy. The Bruch's membrane we talked about in age-related macular degeneration. Our focus today would be in the foveal area again. We'll see how that happens and why the fovea is involved in vascular occlusion and which type of vascular occlusion and how it is involved. Before we go on and talk about the vascular occlusions, just a few words about red and white infarcts, and I'm sure you know them better than I do. A white infarct occurs because the blood supply loses its arterial circulation, and it's because of an arterial occlusion. The tissue appears white because of extreme amount of necrosis and edema together with no blood flowing into that area. And the loss of tissue function is because of ischemia and necrosis. It's like you turn the tap off and you don't get any water. Red infarct is because of venous occlusion, and the tissue appears red. It's just like standing on a hose. The tissue appears red because the drainage is sort of impeded. And the loss of function now is because of ischemia and necrosis, but also because of edema. And edema is happening because of poor clearance from the tissue simply because of pooling of blood. And as the blood cannot drain out, that necrotic debris tissue edema can't be cleared up properly because the eye does not have any lymphatics. So you get a lot of edema. So loss of tissue function is ischemia and necrosis, and in addition edema as well in this case, because it's not possible to clear it up because the blood keeps pooling. It cannot be sort of, drained out, whatever necrotic tissue and damage is taking place. And it's just like standing on a hose, so that, you get this large expanded area of the hose because things cannot get out. Red infarct on the right, white infarct on the left. Now we'll be talking about retinal vascular occlusions, and this is their classification: arterial and venous. Arterial is classified into central and branch, as is venous. The difference is that the central venous occlusion is further subclassified as non-ischemic or ischemic. We'll see what that is about. We'll start off with retinal arterial obstructions, and they are pretty rare, about 2 per 100,000, and the branch artery occlusion type is even rarer than this. It's usually seen in the older age group, more than 70 years. And as I said, we are just approaching where our life expectancy is about 70 years or slightly more. Don't quote me on this figure. So we have started seeing this disease, but not as much as you might see it in other demographics where you have a larger, older population. Males outnumber females by 2 to 1. It's usually a unilateral condition, but you see some bilateral cases, about 1 to 2%. And the right and left eye are equally affected in the central retinal artery occlusion. In branch retinal artery occlusion, it's the right eye that has a preponderance of branch occlusion, branch arterial occlusions, as compared to the left, and that's simply because of the source of the embolus that causes a branch artery occlusion is from the heart. Thus, the involvement of the right eye more as compared to the left, and I'm sure you know why that is. Let's talk about the risk factors for arterial occlusion, and at the top of the list are metabolic disorders: hypertension, diabetes, hypercholesterolemia, hypercoagulability, and atherosclerosis. These are the most common set of disorders that are responsible for an arterial occlusion. Autoimmune in the form of giant cell arteritis is something that should always be kept in mind. You don't see a lot of cases of giant cell arteritis, or at least diagnosed cases of giant cell arteritis, probably because our population life expectancy is very close to the age where you actually start seeing this disease. So this is probably one of the reasons. Again, this is anecdotal evidence. This is not something that is, at least I don't know of any study being done in Pakistan that relates giant cell arteritis to an artery occlusion, retinal artery occlusions. You can have cardiac risk factors in the form of atrial fibrillation and endocarditis, which eventually lead to emboli formation and can cause arterial occlusions. And finally, direct trauma to the retina or the optic nerve can lead to an arterial occlusion as well. So how do all these risk factors actually cause an arterial occlusion? For central retinal artery occlusion, the exact cause is actually speculated to be a thrombus formation in about 75% of the cases. Some of the cases is because of the presence of an emboli. The reason that this we don't really know, or it's a speculation, is because the retrobulbar part of the central retinal artery is too narrow or too small to be imaged appropriately to get an idea as to what is causing the occlusion. A branch retinal artery occlusion, majority of the causes are because of an emboli. So the thrombus formation is because of either atherosclerotic plaques, congenital anomalies of the central retinal artery, which might preclude it to develop an obstruction, hypercoagulable states, inflammations, direct trauma, while the major cause of branch retinal artery occlusion was an emboli, and they could be of a cardiac or carotid source. They are of 3 types: cholesterol, platelet, fibrin, or calcific. The sources of those emboli are also listed next to their. So how do these patients present? Well, since the retina is not receiving any blood, the patient is obviously going to lose his vision, and it's basically a sudden and painless type of visual loss. It's usually to light perception or to no light perception. To no light perception is obviously less common than light perceptions. Some of the time it begins as flickering vision, which is called amaurosis focus. The vision comes and goes as the occlusion is sort of getting to a stage where the retina is now deprived of enough nutrition so as to the retinal neurons not being able to carry the stimulus all the way back to the visual cortex. In branch occlusion, it's a loss of visual field more than a loss of visual acuity, simply because you have a branch affected. And obviously, if the foveal or macular perfusion suffers, you will have a loss of visual acuity as well. And RAPD is always seen in central retinal artery occlusion unless it's bilateral, which then it becomes really, really rare. And the retina appears very pale, and that's because of a lot of edema and ischemic cell death, and leads to the formation of a white infarct. But by 6 weeks, the retinal pallor resolves, and the pallor resolves simply because you have bypass channel formation, which can sort of lead to some perfusion of the retina. But since the retinal neural elements are there, the visual acuity is not really going to recover all that much. Since the retinal elements are dead, and we have talked about the transmission of visual impulses from the retina when we were talking about open angle glaucoma, once you have an interruption in the process of transmission, you start losing your neurons within the rim of the optic disc, and then you will obviously have atrophy starting there. So, and that's just a consequence of loss of retinal neural elements. Collaterals we have talked about. Neo-Vascularization, there's about an 18% chance of development of neo-vascularization, and that is just because of release of VEGF from a dying retina. Together with the pale retina, you will also see something called a box scarring effect. And the box scarring effect is the blood column is actually broken because the velocity of blood flow is extremely poor in the arteries secondary to occlusion. You might even see it in the veins because of very, very poor blood flow. And finally, you see something called a cherry red spot on the fovea, which is something that you see in a central retinal artery occlusion. So this is a cherry red spot. These are your really thinned out retinal arteries, and you can see blood column broken here. This is box scarring, and this is simply happening right here. This is a box scarring in the vein. This is broken columns of blood in the retina, because these are the retinal arteries and these are the retinal veins. The arteries, remember, are thinner in the vein. So this is box scarring in the vein. This is box scarring in the retina. I'll show you a better picture of box scarring in the artery, of the retina, and this is box scarring in the vein. I'll show you a better picture of box scarring. This is the cherry red spot, and a cherry red spot appears simply because, remember, the fovea is convex because it has less thickness as compared to the rest of the retina. So when the rest of the retina becomes edematous and necrotic simply because of the destructive processes secondary to occlusion, the area or the thickness of the fovea increases the least simply because it was the least thick to begin with. So while the rest of the retina surrounding the fovea has its choroidal glow blocked, you can still see the choroidal glow in the foveal area because there is less edema here as compared to the surrounding retina. So thus you see this cherry red spot. Think of the edema in the surrounding macular area or the retina as a large cotton wool spot. Remember cotton wool spot from diabetic retinopathy, which was coagulative necrosis happening because of death of the retina in response to ischemia. Well, this is death of the retina in response to ischemia on a much larger level. So the retina is basically one giant cotton wool spot and edematous and thick. But since the foveal thickness is the least, the effect of edema here is the least. So you can actually see the choroidal glow, and this is why your fovea appears red, thus a cherry red spot, while the rest of the retina is so thick that it is blocking the choroidal fluorescence. And this is again an example of a white infarct, and I'm sure you figured that out by now. No? Yes? I'm sure you have. It's an arterial obstruction or occlusion, so it has to be a white infarct. So this is how a cherry red spot develops. This is a normal retina with normal retinal circulation. This is a cross section. This is how you would see from the ophthalmoscope on the right, and this on the left is a cross section, and this is a blood cell that is, indicative of normal flow. So what happens is, once you have development of an obstruction and you don't have any new nutrition coming into the retina, obviously the retinal elements start dying off, and that causes an increase in thickness because of that large cotton wool spot or simply necrosis and edema. And since the foveal area has the least thickness to begin with, it will be least affected by the effects of the edema, so you will be able to see the underlying choroidal glow from this region, while in the rest of the retinal area surrounding the fovea, the glow would simply be blocked. So if I can go back, this is the normal retinal thickness, and this would be the thickness in response to an occlusion simply because of necrosis and edema. And the fovea does increase in thickness, but relatively less as compared to the rest of the retina, and not enough to block the choroidal glow from coming through, and thus you have the cherry red spot. This is a central retinal artery occlusion because of an embolus, and this is basically a fibrin embolus that is causing a central retinal artery occlusion. You can also see box scarring right here, pretty prominent, and you have a cherry red spot right here. This is again that clot, and this is the same eye, which is 3 months later, and you can see extensive neo-vascularization, although the chance is 18% it can still occur. This is an FFA. This is a normal FFA on the right. On the left is an FFA of a person who has suffered from an arterial occlusion, and FFA is not necessary at all because you can just visually diagnose it, but since we have an FFA to show you, we'll show you, and as you can see, it's very poor filling of the dye in the retinal vessels because of the central retinal artery occlusion. And the veins are sort of devoid of dye as well because there is nothing to return. This is a branch artery occlusion, and the only question here is which artery is blocked, the superior or the inferior. And obviously the pallor area is the one that's going to suffer the occlusion, because remember, these are all examples of the white infarct. So this is an example of an inferior BRAO. This is an example of a superior BRAO. So this person who is suffering from an inferior BRAO would suffer a superior field loss. Remember, retinal images are inverted vertically and horizontally from our discussion on glaucoma. This is an example of superior BRAO. This person would experience an inferior field loss. Field would be the visual field. This is a branch of a branch occlusion. You can actually see where the embolus is. So this is a branch of a branch occlusion. Superior branch of a superior central retinal artery is blocked right here, most likely. So investigations, as I said, you really don't need any investigations to figure out that you have had a central retinal artery or a branch retinal artery because it's visual. However, you do need to investigate to find out why that happened. So you need ESR inflammatory markers if you're looking for giant cell arteritis, carotid Doppler if you're looking for clots or plaques that can form an emboli, lipid profile, blood sugars, amongst others that you might find depending upon the risk factors that you see. Management. Because the retina is just a bunch of neurons, or 9 neural layers, one pigment layer, and as soon as they start becoming ischemic, they pretty much die off in about 105 minutes. So there are many things that have been tried, but none of them really work. Carbogen breathing, bag breathing, lowering the IOP, fibrinolytic therapy, ocular massage to dislodge the clot have all been tried, but they are not really successful. In fact, fibrinolytic therapy with tissue plasminogen activator actually has led to deaths because of intracranial hemorrhages. So there is no evidence that nothing really works. There is personal evidence of what could be best described as sporadic evidence that somebody tried something, one of these things, and it worked. But there is no large RCT based or higher quality evidence that would tell you, yeah, one of these things works, so you can try it. The idea is definitely to manage the systemic conditions to protect the other eye. And if you have giant cell arteritis, the idea is to protect the life of the patient and obviously to preserve the vision in the other eye. So for giant cell arteritis, you would obviously need a cardiologist or a rheumatologist or a cardiologist and a rheumatologist basically to help figure out the exact modality to treat these patients, and maybe a geriatric specialist because of the age of these patients. And other conditions, diabetes, hypertension is again as required. You would need endocrinologist or again cardiologist, depending upon what is the associated risk factor that you can find in your patient that led to an event that caused the vascular occlusion, the arterial occlusion. The outcome, as I said, that both of these do have a central and a branch retinal occlusion. You have the possibility of retinal neovascularization and iris neovascularization. It is seen in CRAO as we said, about 18%. We also saw a picture of retinal neovascularization, but it's very rare in BRVO. And again, it's the VEGF that's releasing from ischemic retinal cells just before they're dead that causes the vascularization. Retinal neovascularization can cause vitreous hemorrhages, which basically go unnoticed by patient because the patient's vision is so poor. Remember, the poor vision tends to persist simply because once the retina is dead, those neural elements are not going to come back. Iris neovascularization can cause neovascular glaucoma. We have talked about neovascular glaucoma in diabetic retinopathy and in angle closure as well. So you can refer back to those sources if you would like to know more about what neovascular glaucoma is. Again, managing neovascularization is very similar to what we did when we were talking about neovascularization in diabetic retinopathy. You have intravitreal anti-VEGF therapy or PRP. And obviously, if you have neovascular glaucoma, you need to do surgery because medical therapy does not work in it. And obviously, you need to decrease the stimulus for VEGF production. So you need to do PRP or anti-VEGF therapy to reduce the stimulus. Otherwise, even if you do surgery and the stimulus is still around, the patient is not going to recover from neovascular glaucoma. So this is a very special case of a 65-year-old gentleman who presents with sudden and painless loss of inability to see objects around fixation. So he can see the patient's face, but not anything else, or his smile or features of his face, but not the entire face from the right eye. He's a diabetic and hypertensive. Visual acuity is 6.6. He has a RAPD and he has a pale fundus. And what do you think is happening? If you were a betting person and you said cilio-retinal artery, you would be right and you would have won something by now. The vision is 6.6 simply because of the presence of cilio-retinal artery. And we talked about cilio-retinal artery. I'm sorry, I was covering my face. We've talked about cilio-retinal artery as coming from the choroidal circulation supplying the foveal area. So if you have a central retinal artery occlusion and you have a cilio-retinal artery, that will still perfuse the inner layers of the retina. The outer layers are perfused by the choroid. The inner layers are going to be perfused by the retina. So you will have good vision because of the cilio-retinal artery. The cilio-retinal artery saves the day here. Same picture as we saw before, nothing new here. And now we will talk about retinal venous occlusions. We'll continue our discussion and talk about venous occlusions now, and this is slightly more involved because the central venous occlusion is of two types. This is the second most common vascular disease of the retina after diabetic retinopathy, and again, old age is the most common demographic seen with regards to age, but these patients are about 10 years younger than those of a retinal artery occlusion, thus they're about 60 years or older. And again, unlike retinal artery occlusion where males were outnumbering females, here males and females are equally affected. For central vein occlusion, the most common risk factor is metabolic disorders, diabetes, hypertension, hypercoagulability, hypercholesterolemia, smoking, and it's an expanding artery that occludes the vein. We'll see how that happens, although it is also possible for direct venular clotting to happen. Trauma, just like it can cause arterial occlusion, can also cause a venous occlusion. A branch occlusion, on the other hand, is by far most commonly caused by an expanding artery at an AV crossing. The other cause is again thrombus formation, which is rarer as compared to the expanding artery occluding a vein at an AV crossing. As we have talked about before, a central venous occlusion is of two types, an ischemic and a non-ischemic, or which is also called a complete or an incomplete type. And this is basically based on the level of obstruction within the vein. If the vein is partially obstructed, there is some nutrition coming in. So the things are not that bad in terms of visual loss and the sequelae or what happens afterwards. And this is the more common type of the central vein occlusion that you see. So 75% to 80% of all your patients tend to present with this type. However, it is possible for a non-ischemic type to convert to an ischemic type. The other type is obvious. So as we've already talked about before, the central venous occlusion is of two types. A non-ischemic type, which is also called an incomplete type, is because of a partial obstruction to the outflow of blood, i.e. a partial venous occlusion. Here, the word non-ischemic does not mean no ischemia. It simply means relatively less ischemia. It's the most common of the two varieties, seen in about 75 to 80% of all patients. However, it is possible for a non-ischemic variant to progress to an ischemic variant. And an ischemic variety is when you have total obstruction to outflow of blood. It is less common. And again, ischemia means more ischemia as compared to the non-ischemic variety. The branch retinal vein occlusion is 3 times more common than the central retinal vein occlusions, which is the other way around, since central retinal artery occlusion is more common than a branch retinal artery occlusion. So I'll just show you 2 pictures and animations which show these 2 types of occlusion. So here we have an artery that is supplying blood and a vein that is partially obstructed. So there is some edema and some obstruction to blood flow and some level of ischemia. So this is your tissue, and it is sort of expanding in response to the edema and necrosis that's happening because of a partial obstruction. And the color of the retina this time is going to be red. This is a red infarct because of outflow obstruction. Let's look at the complete variety. In a complete variety, there is a complete obstruction to blood outflow. So there is more back pressure, more accumulation of blood within the tissue. The tissue would be more red, and it would also be more edematous and would also have more destruction. Because in the first case, there is at least some nutrition coming in because there is some outflow of blood. Here, there is very little nutrition coming in because there is pretty much a complete obstruction to the outflow of blood. So this tissue is much more edematous. There is many more hemorrhages, as you'll see before, and you will also see a lot of tissue destruction or ischemia as well. So this is the pathogenesis in central retinal artery, in central retinal vein occlusion. Sorry, we decided that it's an expanding artery that causes the occlusion, and that is because an expanding or an atherosclerotic central retinal artery will cause turbulence of blood flow in the central retinal vein, and that would cause an obstruction or formation of an obstruction, a thrombus formation. A thrombus formation in the vein can also happen directly because of hypercoagulability. A branch vein obstruction, it's 3 times more common than a central vein obstruction, and it happens at an AV crossing. And remember, AV crossings generally in a normal individuals are good because they are protecting the vein from the effects of the intraocular pressure. But if the artery starts expanding in response to atherosclerosis or other reasons, it would compress the vein itself now. Think of it as a mother hen who is now squashing her, what are they called, chicks. So this is the more common reason. It is possible to have a direct thrombus formation in a branch vein because of hypercoagulability, but by far the AV compression or the artery compressing the vein at an AV crossing is a more common reason. So this is again the picture that we saw before, and central vein occlusion mechanisms are an expanding central retinal artery, and I'll show you that by the red arrow right here. Behind the lamina cribrosa causes turbulence of blood flow in the vein, which causes the thrombus formation. And the thrombus formation directly usually tends to happen anterior to the lamina cribrosa, as indicated by a blue arrow, which is because of hypercoagulability. This slide shows how a venous occlusion occurs at a AV crossing, i.e. a branch vein occlusion, and an expanding artery compresses the vein, which causes turbulent blood flow, which causes thrombus formation, which can cause a vascular occlusion. You can have thrombus formation directly in a branch retinal vein, and that could be because of hypercoagulability. The artery expanding by itself can also just cause venous occlusion at an AV crossing just because of its caliber and its compressive effect. So the red arrow is showing you the expanding artery, the blue arrow is showing you the vein that is being compressed by the expanding artery. This is normal AV crossing, and this is how an expanding artery has now compressed the underlying vein. Patients of central retinal vein occlusion present with sudden and persistent loss of vision. The amount of visual loss is different between the ischemic and the non-ischemic variety. In the ischemic central retinal vein occlusion, you have a very severe loss of vision. The presenting vision is less than 660, and this presenting vision is, within a couple of days of the event. And this loss of vision is primarily because of ischemia and less due to edema. As opposed to a non-ischemic CRVO, where the vision loss is still there, but it's more moderate. The presenting visual acuity is between 618 and 660. And the cause of visual loss is now more edema as compared to ischemia. In a setting of branch retinal vein occlusion, you again have a sudden and persistent loss, but this time the loss is mostly of a visual field in the area that was drained by the vein. You might have a visual acuity affected if the edema that develops starts affecting the macular area and the foveal area. RAPD is generally only seen in the ischemic type of CRVO, and in this case, rather than the retina appearing pale, the retina appears red. It's called a battlefield fundus or a stormy sea fundus or a sunset fundus, indicating that there is a lot of blood. And you see a lot of blood or a lot of hemorrhages simply because of the back pressure. The blood is coming in through the artery, but it's not being drained away by the vein, so the tissue becomes red. You might also see vitreous hemorrhages. These hemorrhages are cleared over a period of 6 to 12 months. And they are cleared up as collaterals develop, so some venous drainage starts off again. But the macular edema that happens in both varieties can persist even once you have the hemorrhages and most of the edema clear up. Macular edema can still persist and cause some loss of vision, especially in the non-ischemic variety. This table is basically telling you the features that help differentiate an ischemic from a non-ischemic central vein occlusion. We have talked about most of these before, and obviously because an ischemic type of a central vein occlusion is a more severe event, it is going to have more severe presentation. It will have a greater visual acuity loss. It will have more edema and ischemia. You will see an RAPD. The visual loss here would be mostly because of ischemia. You would have a greater chance of retinal neovascularization as well as neovascular glaucoma secondary to neovascularization of the iris. And this is a very special type of glaucoma that happens after a vein occlusion. For a very long time, it was called 100-day glaucoma because people couldn't figure out why it was happening after a vein occlusion and why specifically about 90 to 100 days, between 3 and 4 months after a vein occlusion. Now we know it's because of VEGF release, but at that time, people didn't know. And obviously, we've already said that a non-ischemic type can progress to an ischemic type as well. So this is a fundus appearance of a person who has suffered a venous occlusion. You can see hemorrhages in all retinal quadrants together with hard exudate formation. And this hard exudate formation is just again because of the macrophages that are here to clear things up, and they just eat up all the fat from the plasma, lipoproteins and other forms of fat and becomes foam cells. Another picture again, foam cells. And this is macular edema. This is normal. You've seen pictures of edema before when we talked about diabetic retinopathy. And this is basically because of fluid accumulation. And in setting of a non-ischemic variety, this edema, this macular edema, is the major cause of decrease in vision. But do remember that we see edema in both varieties, ischemic and non-ischemic. In fact, we see more edema in the ischemic variety simply because there is no clearance of edema because the outflow channel is totally obstructed and the retina does not have lymphatics. But the loss of vision in a non-ischemic variety is more because of edema as compared to ischemia. So it does not mean it has more edema. It just means that non-ischemic variety, the loss of vision is more because of ischemia as compared to edema, though the ischemic variety would have more edema and more ischemia as compared to the non-ischemic variety. But the ischemic variety visual loss is because of ischemia more and edema less. We have talked about this before, and I'm sure you understand it, irrespective of my using edema, relative, more, less, ischemic, non-ischemic. You can go back and refer to the table if you are sort of confused. What was more and what? That table is correct, by the way. Just remember that visual loss is more because of edema in a non-ischemic variety and more because of ischemia in the ischemic variety. Ischemia, ischemic. This is a branch vein occlusion, and I'm sure you can recognize that it's the inferior branch vein occlusion, and the occlusion probably started here because the hemorrhages start spreading out from this point in time, and this is basically at an AV crossing. You can also see sort of beginning of some form of edema, but not that much in the macular area. And this is the normal retina. So if he has an inferior BRVO, the superior field loss is what he would be experiencing or she would be experiencing. This is a superior BRVO, and this is again the point of obstruction, and again at an AV crossing, and you can see the hemorrhages are beyond this point. So this is where the obstruction was, and you can see a lot of hard exudate and a lot of edema forming in the macular area in this patient. So again, the diagnosis is visual, and we investigate in order to find out what was the cause behind the occlusion. And again, they're very similar to what we were doing when we were talking about retinal artery occlusion. So how do we manage it? For a complete or ischemic CRVO, we do monthly follow-up, and our biggest issue right now is development of retinal and iris neovascularization, and obviously management of edema. If you start seeing neovascularization, you can do PRP or anti-VEGF. If you see extensive macular edema, you can give intravitreal anti-VEGF for 6 months till resolution. For an incomplete or a non-ischemic CRVO, we do monthly follow-ups to manage macular edema now, because remember, there is more edema here, and again, it's an anti-VEGF injection every 6 weeks until the edema resolves. Neovascularization here is very rare, but again, we do a PRP or an anti-VEGF. I'm sure you remember PRP is pan-retinal photocoagulation, and I'm sure you know what it is. If you've sort of forgotten, you can go back to these diabetic retinopathy, PPT, PowerPoint, or video discussion. It'll help you clear things up. For a branch venous occlusion, we do a 4-month follow-up, and again, we are looking for edema and neovascularization. Macular edema, you do grid laser or anti-VEGF. Again, grid laser is explained in diabetic retinopathy session. Neovascularization, you do retina in the affected area. Because remember, it's a branch occlusion. You won't have neovascularization everywhere, only in the affected branch. So you just do laser in that part. You don't need to destroy all of the retina, i.e. you don't do PRP or anti-VEGF. Since anti-VEGFs have come around, laser is very, rarely used or used in combination with anti-VEGF. And obviously, if you're doing anti-VEGF, you do a monthly follow-up and not a 4-monthly follow-up. So let's talk about the course and outcomes. In all variants, CRVO and BRVO, the hemorrhages and the edema tends to clear up between 6 and 12 months as collateral develops, but there is a chance that some edema does tend to sort of persist. In non-ischemic CRVO, there is about a 10% chance that the patient would have a full visual recovery with appropriate management of macular edema, not all spontaneously, magically, auto-magically, no, by appropriate management, yes. And it's very rare for neovascularization to develop. In ischemic CRVO, there's always some level of visual loss that might persist, and that's probably because there is more ischemic damage, and probably also because of some persistent edema, but mostly because of ischemic damage. Neovascularization is common, and we've already talked about that. It usually is something that occurs within 100 days of occlusion and is called the 100-day glaucoma. And we now know why it is happening. Previously we didn't, and we used to call it 100-day glaucoma because it happens after 100 days of vein occlusion, central vein occlusion. Now we know it's because of VEGF release. And for BRVO, you would expect good visual recovery, but sometimes because of persistent macular edema, in spite of the best treatment, you have some loss of visual acuity. Retinal vascularization in about 20% of the cases, neovascularization of the iris, and thus neovascular glaucoma are much, much rarer. This is how we inject intravitreal injections. If you have done this many times, so this is more for your review. The site is through pars plana, and you need to ensure in a sterile field, topical anesthesia, ensure that you check IOP after you have injected the agent, because it does cause a very transient ride, but after about 30 minutes, the IOP should be back to normal. The complications seen in venous occlusion include retinal neovascularization, which is most commonly seen in the ischemic or the complete type of CRVO, and it's managed by PRP or laser to the affected area if it is BRVO causing retinal neovascularization, or anti-VEGF injections. Iris neovascularization and subsequently neovascular glaucoma are also seen, and again most commonly seen in the ischemic or the complete type of CRVO. And we have discussed this used to be called 100-day glaucoma because nobody was sure why it was happening, and it happened 100 days after the symptoms of the occlusion started. the glaucoma term used here was, when we refer to it as 100-day glaucoma, was set in antiquity, because at that time glaucoma was simply defined as increase in IOP. So neovascular glaucoma is slightly more appropriate a term. Management of NVG, neovascular glaucoma, we have talked about before when we were talking about diabetic retinopathy, as well as more extensively discussed when we were talking about angle closure and angle closure glaucoma. In brief, you need to reduce the stimulus that is causing retinal iris neovascularization, which is using PRP or laser to affected area, if it's a BRVO leading to neovascularization of iris, which is a rare event, or anti-VEGF injection. Then you do trabeculectomy because medicines don't work. We talked about trabeculectomy in angle closure and angle closure glaucoma discussion. And partial destruction of ciliary body if trabeculectomy is not successful. Again, this is discussed in a little more detail when we were talking about angle closure and angle closure glaucoma. This is it. Thank you very much. If you have any questions, you know where to ask, and I'll see you in your next video discussion.